So good afternoon, and thank you everyone for sharing your lunch hour to hear Brian and I speak today. I would like to start off by saying that neither of us has any actual or potential relevant conflicts of interest that might bias or impact the content of the presentation. So today we're going to present to you on a research study that was conducted at the L'Orange Health Centre to evaluate switching the route of administration of antimicrobials from intravenous to an oral route. Before we dive into the actual study, I'd like to set the stage a little bit and introduce you to our stewardship committee. And so this is our committee here. So we're fairly small, but we like to think we're somewhat mighty. So we followed the IDSA recommendations of having a pharmacist, physician, epidemiologist, and infection control practitioners members of our committee. Our core committee is made up of myself, Marina Facci. I'm a pharmacist. Family physician, Dr. Jeffrey Irving, and he sends his regrets. He's currently on vacation with his family in Ontario. Our auxiliary members are Brian Quinn, and Brian Quinn is a nurse epidemiologist at the Population Health Unit. Coincidentally, he also happens to be my husband and lovingly pointed out that his picture has this yellow angelic hue to it. The other auxiliary member is Wally Salam, and he's an infection control practitioner here at the Population Health Unit. So our committee started up and was prompted by accreditation ROPs that I'm sure most of you are familiar with. Accreditation Canada requires us to have an antimicrobial stewardship committee, and that we have a program which includes various interventions. So in terms of these interventions, our research study is focused on the bolded intervention at the bottom of the page here, which is parenteral to oral conversion of antimicrobials. So this has been coined as one of the low-hanging fruits of antimicrobial stewardship. It does, however, offer various clinical benefits and as well as financial benefits. So it was at this stage when we decided to expand our team and bring in Dr. Cheryl Waldner. And Dr. Cheryl Waldner is a researcher and professor at the University of Saskatchewan. She has a broad array of research that focuses on humans and animals. And for those of you who know her, you'll know that she's exceptionally skilled in research design and applied statistical analysis. So with Dr. Waldner on board, we set out to ask the following questions. The first question was, what proportion of clients at L'Orange Health Centre are eligible for IV to PUO conversion? What proportion of these are not being converted? What factors are associated with failure to convert? And lastly, for clients not be converted, what is the impact on length of stay and readmission within 30 days of discharge? So I'll hand over to you, Brian.
So I thought since Marina had kind of set the stage of the committee, that we would also kind of set the stage a little bit of where the health center is, and for the most part, the population that the health center serves. So the L'Orange Health Center is right around, in and around L'Orange and Orange, so right around this part. The majority of the population that goes to the L'Orange Health Center would be in about an hour, hour and a half from there with most of these communities. However, there are some outpost communities such as Pine House over here, as well as some fly-in, fly-out communities such as Wollaston Lake way up here. So in general, the L'Orange Health Center's service area is about 15,000 people. It's spread over a very large geographic region. In terms of the population itself, there's a lot of challenges for many of the communities that are within the L'Orange Health Center service area. So this particular chart just shows the median household after-tax income, and it's pulling most of the census subdivisions, which for the most part, a census subdivision is census terminology for a community, a town, a village, something along that line, a reserve. And what you can see is Saskatchewan income is around, for household, median income is around 66,000. There's a couple of the communities that do very well financially, but the majority of the communities are struggling quite a bit with incomes about a third of what the provincial would be. Another important social determinant is crowding, especially when we start thinking about skin and soft tissue infections. This looks at the percent of the private households with more than one person per room. And as you can see from here, Saskatchewan rate as a province is about 2%. Now, the well-off communities in and around La Ronge Service Centre are about 2.5 to 3.5 times that rate. But when you get out into some of the more outlying communities and fly-in, fly-out communities, you have exceptionally high crowding rates, in some cases getting close to 50%. I won't go into many of the other social determinants, but essentially if you look at any of those other social determinants, you'll see very similar things. Overall, the La Ronge Health Centre service area is basically a very small population spread over a very large geographic area that really struggles with most of the determinants of health. In terms of the study design that we actually did, we used a retrospective cohort design. We pulled a good chunk of the data from the hospital discharge abstract database, including age, sex, community use and residence codes, major clinical category, length of stay, and if the discharge was a readmission within 30 days. We had to supplement that with information from a chart review. This data included things like the eligibility criteria, information around IV to PO conversion, as well as most of the medication information. In terms of our inclusion and exclusion criteria, we essentially screened all the adult inpatients that were age 20 plus over a 4-year period between April 2011 and March 2015. Now, because we were doing the chart review, we didn't want to have to do a chart review of every single discharge to try to find out which clients were eligible to be included in the study. So essentially, we did a screen of the initial discharges by their most responsible diagnosis. And essentially, Marina and Jeff had put together a list of diagnoses that were potentially related to IV antibiotics, and that was our initial screen. Then whenever they did the chart review, they essentially used inclusion criteria if they were on antibiotics, IV antibiotics for over 24 hours, they were febrile for over 24 hours, they were showing signs of clinical improvement, and were able to tolerate administration of fluids and tablets. The exclusion criteria essentially was related to severe infections, things like osteomyelitis, septic arthritis. There were some other non-clinical exclusion criteria, such as missing charts or if the person left against medical advice, for example. In terms of our overall primary outcomes and our analysis, in order to determine the proportion of eligible clients that were not converted on time from IV to PO, this was mainly just done by looking at the descriptives, what percentage were and what percentage weren't. When we moved on to the next question in terms of what were the greatest predictors of those who were not converted, we ended up using generalized estimating equation, and this was so that we could control for repeat hospitalizations by using the repeated subject statement and the patient chart. Our model building technique was pretty basic, pretty similar to what others have done. We essentially started with using unadjusted models with the individual variables. And then from there, we essentially screened any of the variables that had a significance level of 0.2 as potentially in the final model. From there, we essentially tried to remove the variables, and any of the ones that were removed, we tried to check and see for confounding. Our confounding checks, for the most part, were looking at changes in the resulting betas and if there was a change of 20% or more. Once all of the confounding checks, both on the removal of variables, as well as we did check a few of the variables that didn't make it into the model that we thought were potential confounders, we then moved on to interaction checks. We essentially only looked at two-way interactions, and we looked at those interactions between models in the variable, or variables in the model, as well as a few that we thought were important that didn't make it in, but were potential interactions, and we checked those with significant values of 0.1 variable in the model. That essentially gave us our overall model, which we used, as we had just mentioned, in order to try to predict what were the greatest predictors of not being converted on time. However, we also wanted to use it in order to calculate propensity scores that could be used in the other outcomes for primary outcomes 3 and 4 on readmissions and length of stay. For those who aren't as familiar with propensity scores, essentially a propensity score is the probability of being assigned to treatment. Now, in our case, it's essentially the probability of being not converted, using all the covariates of interest. So that moves us on to those last two primary outcomes. So in determining if those who were not converted were more likely to be readmitted in 30 days. Again, we used a very similar approach in terms of the analysis. We used GE for it so that we could control for that repeat hospitalization. The major difference here is instead of needing to use all the individual variables and building our model up, we used essentially the propensity scores to adjust for confounding. Now, the flip side of that is when you use propensity scores, you have to do some checks, and some of those checks can mean other things being added to the model. So I thought I'd just quickly go over our major checks with propensity scores to show you what our model eventually looked at. So we did run the model with the individual variables instead of their propensity scores, but in this case, we couldn't get convergence on the model with the individual variables, which is in some ways kind of expected. We had low readmissions, and that was the whole point of using propensity scores. We did check to see that there was good overlap between the propensity scores and the independent variable. We also checked for linearity between the propensity scores and the outcome variable. Unfortunately, we did see a problem there, so we had to include the quadratic term or the interaction term in the model for that. Now, there's an additional step that some people use when they're using the propensity scores, and that is you look at other variables that may not have made it in the calculation for the propensity scores, but you think that they might have an impact on the outcome model of this particular analysis. So for us, we thought that the community variable would be a potential could have a potential relationship with the outcome variable of readmissions. So we tried to add that along with the propensity scores into the model. Unfortunately, we couldn't get convergence once we put that community variable in it, so we had to remove it, and thus our overall model essentially was the propensity scores were the ones that were added in it, along with that interaction term. And our last analysis was on length of stay. Again, we used a very similar approach that we did with readmissions using the GEE. We also used the propensity scores as a way to control for confounding. In this case, we were able to compare the models when we ran the individual variables as well as when we ran just with propensity scores. But the propensity scores had a better model fit. So that was a good thing. It kind of highlights one of the benefits of propensity scores. We also seen the good overlap, again, with the propensity scores, the same independent variable. This time, there wasn't an issue with linearity, so we didn't have to include that interaction term. We were able to run with the community variable, as we thought that may have an impact on the length of stay. However, once we put it in the model, it was a non-significant term, and when we compared the models with it in and with it out, the model with just the propensity scores was a better fit, so that was the model that we used. So now I'll turn it over to Marina, and she can go through the results and discussion with you.
Okay, so for our results, we'll start off on the slide looking at our patient population. And so we started off with 518 patients, and from there we had an exclusion of 288 were excluded and 230 were included. Of the ones that were excluded, the two major reasons for being excluded were that they were not on oral antibiotics or they were not clinically improving. When we dive into patient characteristics a little bit more, so we'll start off here with the major clinical category. So the two leading clinical categories here are diseases of the respiratory system, as well as skin and soft tissue, and there's a fairly similar spread between the others. When we look at age group, the majority of our patients fall here. They were between 20 and 64 years of age. When we look at sex, we see there's a very similar number of males and females, slightly higher for females at 57%. When we look at ease of medication conversion, so a med that would be easy to convert would be one where there's an IV and oral form to the same drug, we see that we have about an even split here. When we look at days eligible for conversion, we see that the majority of people are eligible during the weekday, which makes sense since there's 5 days of the week. When we look at readmission for our patients here, what we're seeing is the majority are not readmitted, so 92% of patients are not being readmitted. Lastly, when we look at community here, we see that the bulk of our patients are from community 1 and that there's a fair spread in where our patients are coming from the other communities. So as far as our primary outcome number 1 goes, in terms of determining the proportion of clients that were not converted on time, we see that we have about a 50-50%, so we have 51.7% that are not converted. So this takes us to our next primary outcome, which was to determine the greatest predictors of those that were not converted in time. So this is a list of variables that were included in the unadjusted model. And in our final model, we ended up with major clinical category. We ended up with day eligible to be converted. We see that we're close to significance here. And age group we kept in because the age group turned out to be a confounder. We also looked for interaction terms, of which there were none. So at this stage, our greatest predictors were major clinical category and day eligible to be converted. So if we now look at the differences within those categories, what we see is that on the weekend, there's a greater likelihood of not being converted. Also, if you have a skin and soft tissue infection compared to kidney, urinary tract, and male reproductive system, there's a greater likelihood of not being converted. As well, if you have a skin and soft tissue compared to ear, nose, mouth, and throat, you also have a greater likelihood of not being converted. Next, when we look at readmission within 30 days of discharge, what we see here is that there was no difference between the 2 groups in terms of readmission rates. We then looked at the average length of stay, and what we see for those converted in time, this was an average of 2.39 days, and for those not converted in time, it was an average of 4.33 days, so about a 2-day difference in length of stay. So this slide here just summarizes our major findings. And so our first question was, what proportion of clients at L'Orange Health Center eligible for IV to PO conversion are not converted? So we're at 51.7%. When we look at factors that are associated with failure to convert, one of them was being eligible for conversion on the weekend, and a second one was having a skin and soft tissue infection. For clients not being converted, we see that the impact on length of stay is an increase in hospital stay by about 2 days. And when we look at readmission within 30 days, we see that there was no difference between the 2 groups. So this brings us to our future steps. So what we would like to do is to increase the conversion of IV to PO medications for patients who are eligible. And so we'd like to use a checklist as a reminder. We'd also like to identify supports that are required for weekends to ensure that patients are converted in a timely manner. And we'd like to determine the specifics around the management of skin and soft tissue infections. This brings us to our acknowledgements page. So I'd like to thank Robert Parker and his team. Robert Parker has come up to L'Orange and met our team. He's provided us with substantial support in trying to develop a northern antibiogram. And with regards to this project, he provided us with funding for a PharmD summer student by the name of Nikola Vidovic, who we had the pleasure of hosting for 2 weeks. I would like to thank Dr. James Irving, who's a medical health officer in the North, and he was involved in the research approval process. He provided us with some really good suggestions that helped to make our study better. And lastly, I'd like to thank the former Mamaweeton Churchill River leadership for approving this unorthodox project, whereby we did a lot of the work over our noon hours when our kids were fast asleep. As well, Brian took quite a few vacation days to visit Cheryl in Saskatoon and work on the statistical analysis. So I'd like to thank them for their support. And at this stage, I'd like to thank you all for your attention. We'll open the floor up to questions. And like Jason said, if you want to, you're more than welcome to email any of us at any time if you have any questions. And with that, I'll open the floor up. Thank you.
Thanks, Marina and Brian, for a great talk. I don't see any questions in the chat, so if anyone has any burning questions, you can feel free to unmute your microphone and ask away. I am going to take advantage, since I'm already talking, of asking you guys a question and maybe give the people a minute to think. I'm really interested, Marina, in why do you think skin and soft tissue infections are the ones that stood out as, you know, people not being converted when they could be?
It's an interesting question, Jason, and I posed it to Dr. Jeffrey Irving as well. And his thoughts were that because you can actually visualize the pathology, he thinks that's what some of it is. And his comment was that if we did x-rays on some of our respiratory patients, he thinks our IV conversion rates might be worse. So that was that's one possibility.
So if they don't see it, they're more likely to switch you to something oral.
Yeah, possibly.
It's interesting. Thank you all very much.